Good morning. Dr. Badia here for another bi-weekly episode of Fixing Healthcare from the Trenches. And I'm honored this morning to present a colleague and friend, Dr. Nick Rose from California, Southern Cal, who is a hand surgeon and faces a lot of same challenges that I do. And as you know, with this podcast, we try to focus on clinicians who are passionate about trying to improve our healthcare system. We'll be focusing on certain areas, some of which we share a lot of ideas. Dr. Rose, basically most of his education training at UCLA. It's a powerful program, and then went and did a hand fellowship with really an iconic figure in hand surgery, Dr. Green in San Antonio, and then went back and is now strongly affiliated with UCLA and Harbor UCLA Medical Center. So reality is that we're facing a lot of the same issues. So he's going to give you our perspective, and I'd like to welcome Dr. Nick Rose.
Thank you, Dr. Badia. I really appreciate you having me on the show. And I know we have a lot of the same ideas, and even though we're on different coasts, a lot of the same frustrations, both for our practices and where we see medicine going in general.
Absolutely. And hopefully we're going to have, maybe you have some updates. We're going to be at the Hand Society in Minneapolis this year, right? And I think we're going to be doing an instructional course on work comp. Is that, I don't know if that's gone through.
I think so. We're going through the approval process now. We have a lot of business related, courses going on. As you know, I'm the co-chairman of the Business of Hand Surgery Committee,
Yep.
which I think is a very important probably position here in the American Society of Surgery of the Hand, especially with the changes in medicine that are going in from a business standpoint. A lot of private equity firms and hospitals buying practices, and really we're seeing before us private practice is slowly dying.
It is, although I've been hearing a lot of talk about some resurgence. So I think that us physicians are pushing back, and I think probably in your community it's the same. I think people, after almost 30 years practicing here in Miami, I think people finally are seeing that myself and a few others down here are kind of trying to lead that charge. So I appreciate your coming on because, it always takes a number of people to try to enact change. So tell me, we both do. In fact, I know that you gained a lot of passionate followers after I think you did a reattachment of an artist's arm, upper extremity, which for the public, that's an, incredible operation. I mean, actually taking a severed arm, fixing everything to get it, working to some degree again. And that's a common work injury, right? So tell us, what your perspective is in California with these kind of severe injuries to the hand.
Well, the problem is in California is there's, a lot of hoops to jump through. There's utilization reviews, there's peer-to-peer reviews. So what's happening is fewer specialists like me who can really treat those devastating injuries are willing to do work comp. And so what's happening now is when you have these devastating injuries like, avulsion injuries, the fingers, amputations of the arm, really devastating upper extremity injuries that I'm sure you see as well, there's just a smaller and smaller network of doctors who are willing to treat that through the work comp system. So it's very broken. It's very tedious in California. The reimbursement, like everything, is coming down, and it's really approaching Medicare reimbursement. So in order to do that added work of all the reports you need to do, peer-to-peer reviews, utilization review, really many doctors it's not worth doing. And even in our practice, we have cut back on our workers' compensation for that reason.
It's so sad. And, the big challenge, of course, is getting the public to pay attention to this, because until it's their loved one, it's just somebody else's problem. And I'm curious as to what it will take for society to start listening, because I want people to hear this. I mean, you have a very qualified surgeon saying that you have to manage the volume of that because you can't pay the bills. It takes a lot of time. There's too many hoops to jump through. And we should be minimizing that, because the reality is I'm still do work comp in Miami, but I'll tell you, if they cut the rates and they're talking about it, I probably won't either. And at some point, I mean, we all have personal lives, right? And family, and you sacrifice a lot. And the crazy thing is we're willing to do it, But I've always said that these business people, and you alluded to the middlemen, they really are taking advantage of our altruism. But that altruism has limits. And we're seeing it, right, with colleagues around the country who, there are places, Chris Peterson, right, and where you trained in San Antonio, he says they're being flown in from, 500 miles away for a reattachment of a digit because many surgeons aren't doing it. They're up all night, right? I mean, you told people what we were paid to do a microsurgical reattachment of a digit. Most lay people would not believe you. I don't know.
Well, it's interesting you bring up that point. I think one way as physicians we can communicate it is, and, we've been in practice 25, 30 years, both of us. So, we have very loyal patients that we can really talk to. And I think one thing that I found is very useful is, somebody will say, hey, Dr. Rose, thank you so much for fixing my wrist. You really gave me my life back. And, I can't tell you how much I appreciate it. And I will tell them, I said, well, what do you think I was paid for that surgery? And I will tell you that it's very eye-opening because 95% of the time they will give you a figure that's much higher than you were actually paid. For $1,200 here in California, probably $1,000 to $1,200, but they'll give you a figure of $4,000, $5,000, and realize this is for a stressful hour and a half, 2-hour case. So I think a lot of patients actually get upset. They're actually visibly upset that they don't have that knowledge. They don't understand where reimbursement rates are going. And the other thing too, Alejandro, as you know, is you look at the healthcare dollar in the United States. I think it's down to probably 15%.
Yeah, I think it's 15% is us.
15% goes to the doctor, and patients don't realize that. So you have administrators, insurance carriers, all these middlemen making money that really should be going to the nurses, the PAs, the doctors, and those people who are on the front lines.
Yeah, that is a growing focus of mine, is trying to point out and I don't mention that in my 3 points, and we'll get to that in a few minutes with your 3 points, but certainly the minimizing the middlemen is a key area, I think, to focus on. And I think what you're doing, and I need to do a better job of this, is educating the public by doing that. When they ask you, and go ahead and be very upfront, be very transparent, which we need more in healthcare, about what you were paid. And by the way, I had a podcast with somebody from more the business side of employer health and work comp, and he hates the word reimbursement. And when you think about it, it really is terrible. Reimburse, I mean, we didn't pay out anything. Right. Reimburse is when you pay something, you get it back. I mean, we're using our skill and 14 years of education and training to help somebody. We should be paid, right? Like anyone else. So
well, it's not 14 years. You're selling yourself short. I mean, we started at age 5 and end up at 32. That's 27 years. So if you were able to cut corners, they're good for you. I know you did, and I'm just giving you a hard time.
No, you got me beating it because you said you 5 years. Yeah, I was convinced I was going to be a physician, not just a physician, but a surgeon at age 8. So you got me at 5. I love it.
Yeah, it's a long road. It's a long road, and it's a grind. And I think that, people other than spouses really probably don't understand the grind that it is and the stress level that's involved with what we do. I think that we're all perfectionists. I think, like you, I can do 100 perfect surgeries, but that 101st surgery that maybe didn't go quite as well as I wanted, that'll keep me up at night. And it really does beat you up. And I think there's going to be fewer and fewer people willing to do that.
It is true. Yeah. Yeah. It's funny because I had a very long, tough day of surgery yesterday. And I have one case that I'm beating myself up about. I'm going to see her tomorrow, but just a couple points that didn't go so well, but you're right. And, hopefully the public realizes that we do care that much.
Absolutely.
So give me 3 initiatives that you think could really not only fix our healthcare system, but also bring costs down. What would you say?
Well, the first one would be to trim the fat in the system. I mean, in terms of, the money that goes to the administrators, the middlemen, bring more of the healthcare dollar to those on the front line, the physicians, the PAs, and whatnot. There's a lot of fat, as we say, just these pre-approvals and all this wasted time and money that goes into simply, fixing a wrist fracture for somebody who has a shattered wrist, all the hoops you have to jump through. So that basically be really streamlined, number one. Number two, really the insurance carriers are really the bad players here. I mean, I don't understand how, we can read in the paper that the CEO of this insurance company cleared, $30 million, and that's okay with everybody. I think what needs to happen is you could have federal mandates to the insurance carriers that say, if you make this much money, 80%, 75% has to be paid to direct healthcare. I don't know what that figure should be, but I think that would be a way to trim the fat, number one, and also a way to basically make them more accountable.
Well, let me address that, Nick, if I could
Absolutely,
because it's very little known, and until I wrote my book, Healthcare from the Trenches, I did not know this. The MLR is a medical loss ratio. The MLR was bundled into the ACA, known as Obamacare, and that stipulates that depending on the size of the company, it's usually 85%. That insurance company has to spend 85% on patient care. And that sounds great. And when you say it, but here's the loophole. When you present something that's more cost effective, and I know this with my Ortho Now efforts, something that's more cost effective, the insurance companies oftentimes don't grab it as you would think they would, because if they are too efficient at delivering the care, they fall out of compliance with the MLR. So that law has to be modified. And I'm going to be, I'll send you, Nick, an article. A lot of people haven't seen it, but I summarized that. So what you're saying is absolutely on target, but there's some loopholes that need to be fixed. But that's a great idea.
absolutely. And then, I think the third, I have probably 20 I could give you, but I think the third, we'll stick to the work comp system, which is, very broken in many states. And that's why fewer and fewer doctors are treating them, as we alluded to earlier. There are many states like California that have the 1% rule, where work has to be responsible for 1% of your injury. So anything you have, any ache and pain, if I turn my neck to my left and that hurt, I'm at work, hey, there's your 1%. So that's what's draining the work coffers, if you will, in states like California. And because of that, they're wasting more money on these ridiculous claims. So the people who have true industrial claims, the burns for the firemen, the arms being cut off, there's less people to be paid to take care of those injuries.
Wow. Yeah, it's 51% in Florida, just so for Floridian. So that's and even then there are issues in Florida, but I know there are places where it's even more challenging. So hats off to you, honestly, for taking care, and your colleagues for taking care of these patients who really need us. But I hope this doesn't fall on deaf ears.
Let's hope not.
Wonderful. So it's, as often happens, and physicians are more aligned than we probably realize it. My three are that I think we should have, in terms of middlemen, that we should have oversight, not authorization. So authorizations simply clog up the care and slow it down, and each of those steps costs money, right? But we need oversight, right? Because we make mistakes. There's overutilizers. There's some bad apples, right? There's some great shows now, right, on Netflix about bad actors, and of course we need oversight. But we need to eliminate this authorization every step of the way. Second one is people don't talk about this enough, is that you really need to see the right clinician at the right time. I'm sure in your practice, when you see somebody with, say, wrist pain, they probably come in right with an MRI that wasn't helpful. They go through they're seeing all these different doctors when our primary care colleagues should be keeping us healthy and overseeing, more chronic conditions, not seeing somebody with wrist pain. It's like you and I seeing somebody with an eye problem.
Right.
Right. And then the last one, my last pillar is public education. And my biggest challenge is really getting the public to pay attention to something like this. It's very hard to get them interested. And again, when it's their family member, a loved one, or maybe an employer, because I'd love a lot of work comp people to see this particular show, then collaborating with us, maybe we can make some changes.
That's all great points. Yeah. Absolutely.
So what do you think? Final word, Dr. Rose. What do you think's the next step?
Well, I think transparency and education is, and I think people like you, writing the books that you do, I really look up to you in terms of, I wish there'd be more proactive people like you, getting the word out, talking to patients and whatnot. So I really think it's communication. And I really think, certainly our spouses, our loved ones know the sacrifices, we make, how hard this profession is for us. And look, we make a good living. I'm not sitting here saying that, I can't pay my rent and whatnot, but I don't know that people necessarily understand the time and effort and really emotional stress that goes into being a surgeon, being a physician, and not to mention that, you really don't have a life until you're 32 with all the education you go through. So I really think it's education and knowledge and getting that out there, and hopefully, podcasts like this, books like you wrote, are getting our message to the patients is needed steps to get us where we need to be.
Well, it's a good first step, and if we can just sort of keep getting the word out there, and that's the goal of the podcast. So I want to thank you for being on, Nick. I want to thank everyone for listening, and please, when people like it, that's great, but you can share this and share it to people who you think would get something out of it. People who own a business, right? People who manual workers, so they understand the challenges with the system of us, people like Dr. Rose and I taking care of all of you. Just share that, send it along, and join us again in 2 weeks for our next episode of Fixing Healthcare from the Trenches. Thank you, everyone, and have a great day.
Thank you.